A very good afternoon to everyone. First of all, I would really like to thank AIOS for giving me this opportunity and Dr. Swapnil for including me to this instruction course. My topic is surgical management of astigmatism during cataract surgery. So today, due to expectation of perfect refractive outcome, management of astigmatism has become an integral part of cataract surgery. So is astigmatism really our enemy? Should we be even chasing the smallest amount of astigmatism? And why should we worry about astigmatism so much? So actually the small amount of astigmatism, let's say less than 0.5, it actually helps us in increasing our depth of focus. But if the residual astigmatism after cataract surgery goes up above 0.5, the distance visual acuity goes down and the spectacle dependence increases. And it is shown in multiple papers that if the residual astigmatism is more than 0.5, your premium IOLs will lose their wow factor or lose their sheen if your residual astigmatism is more than 0.5. So astigmatism is not really our enemy, but we would like to keep it under control, less than 0.5. So to deal with astigmatism during cataract surgery, we have broadly these two options, the incisional methods and the lens-based methods. In incisional methods, we have on-axis incision, paired opposite clear corneal incisions, limbal relaxing, and arcuate keratotomy. In lens-based procedure, of course, we have toric IOLs. So it's good to know our prevalent practice patterns. This is a survey done by American Society of Cataract and Refractive Surgeons. And basically in this survey, they have divided the astigmatism into 3 categories: mild, moderate, and severe. And for each category, they asked the surgeon that how would they deal with this astigmatism. So for low astigmatism, 0.75, a large chunk of surgeons said that they would do incisional, and small amounts even said that they would not even treat that amount of astigmatism. When the astigmatism goes to 1.25, most of them said that they would go for toric. And when the astigmatism jumps up to 3 diopters, almost all of them said that they would go for toric IOLs. So the first option we have for mild astigmatism is on-axis incision. So it's very simple that you take your phaco incision on the steep axis. In elderly cataract patients, most of the time your steep axis is 0, 180 degree. That is against the rule, and that's why most of us take temporal clear corneal incision. But when the steep axis is at 90 degree with the rule, I most of the time change my surgical position to superior, and it controls like little small amount of astigmatism up to 0.5 diopters. The next option we have is paired opposite clear corneal incisions. So this is very simple and cost-effective technique. It does not need any extra instrument. Here at the end of surgery, we can see the lens there. I'm under continuous irrigation. I'm just poking the keratome opposite to the original phaco incision, and these are the grossly this much flattening it causes for 0.75 for against the rule and 1 diopter for with the rule. The next tool in our armamentarium is limbal relaxing incision. It basically treats the astigmatism at corneal level by taking incision, the partial thickness incisions at the steep axis. It can be done manually or femto-assisted, but for the sake of practicality, I'll just stick our discussion to the manual LRI. It works very well till 1 diopters. You can do it for higher than 1 diopter, but the predictability above this for the higher astigmatism, the predictability goes down. And remember that LRI should be avoided in thin, irregular corneas. These are the 2 nomograms, Donenfeld and Dono, or Nichamin age or Pachy adjusted, or Napa nomogram. These are very important nomograms for a surgeon, but what I do nowadays, I just go to LRI calculator, put in the data, and the site gives me pictorial depiction of LRI incisions. So just to compare the 2 nomograms, the Dono nomogram does not allow you to overlap the LRI incision with the phaco incision. So for this patient, when I did the calculation for 1.25 cylinder, Dono nomogram gave me the 30 degree phaco incision on one side and 85 degree LRI on the other side. So this, it does not allow you to overlap two incisions. So this limitation causes it does not correct more than 1 or 1.25. For the same patient, I did calculation with NAPA, and NAPA gives me two symmetrical 40-degree incision, one of them overlapping with the phaco incision. So most of the time I follow this NAPA overlap technique, and this is how I do it. Initially at the start of the surgery, rather than doing the full arc, which is required, I just do the partial 30-degree arc, which is usually the breadth of phaco incision. And from that partial arc, I just do my phaco incision from the base of LRI. You have to correctly delineate the base of LRI. And after completing the surgery, I'm just extending the LRI incision to the desired arc length at the end of surgery. So basically, initially you do one side just the phaco or phaco breadth, and later you extend it to desired arc length. Now we come to the big daddy of them all, toric IOLs. Toric IOLs have definitely established themselves as the most effective way to treat moderate and severe astigmatism. It's the procedure of choice for that category. And I'm just going to go through a few frequently asked questions and try to answer them in practical point of view. Of course, you can add the questions at the end of the session. So which calculator to be used and why? Already Dr. Swapnil has covered it, but still I'll go quickly through it. Many reasons, but the main reason is that it includes all these important parameters. And the most important of them is posterior corneal astigmatism. Dr. Narendra has already touched this topic, that it is a minus lens and it acts against the rule around 0.3 to 0.5. And during calculation, if we ignore the posterior cornea, just consider anterior keratometry, we'll end up overcorrecting with the rule and undercorrecting against the rule. So what does this mean actually? I'll just depict what I mean by this. I have taken two patients. In patient 1, Sandhya, 0.9 diopters of astigmatism, which is against the rule. And basically the anterior against the rule will add up to posterior against the rule, and we'll need more cylinder to correct this. We'll need around 1.5 diopters for this cylinder at the IOL plane. But the patient 2, Gopal, has the same amount of cylinder, around 0.9, but the direction is with the rule. So this with the rule will get negated by posterior against the rule, and we'll need less amount of cylinder. Actually, for this case, we do not even need a toric IOL. So this is well taken care by Barrett toric calculator. The default setting in the Barrett toric calculator is that it gives you predicted PCA by theoretical formula. But it also has an option of measured PCA. That means if you have any machine like Pentacam, Galilei, where you can measure the actual PCA, you can enter those values, and the calculator will consider those values for the final calculation. The one more important feature of Barrett toric calculator is something called integrated K. Usually we have multiple machines and they give slightly different K readings, and you are confused at which K reading to be used. So basically this calculator has an option that you can enter 3 to 4 readings from different machines, like I have entered here from Lenstar, autokeratometry and Pentacam, and the calculator will give you the integrated K, which will be used for further calculations. SI is very well covered by Dr. Narendra. I'll just quickly go through it. Which value should be entered for SIA in Barrett toric calculator. So the first best thing you do is that you do your vector analysis by comparing pre-op data with the post-op data on this website. But if you cannot do it for some reason, then the next best thing you should do is you can use the value 0.1 if you are doing the small clear temporal corneal incision. So this value basically comes from centroid SIA. This is from Alcon calculator, and this explains it very nicely, that if I do 2 patients, suppose patient A, I induce 0.35 at 20 degree, and in patient B, I induce 0.35 at 110 degree. So traditionally the mean SI is 0.35, that is just an arithmetic mean. And that's what we have been doing since many years. But if we plot these 2 patients on double vector diagram, the direction of these 2 patients are exactly opposite, and in vector analysis, they cancel each other, and that's why the centroid SI is 0 here. And this is what we need for our toric calculation, the centroid SI. And the next final question is, which slender power should be chosen between these three suggestions given by the calculator? So the original thought was that the original axis of the patient, the astigmatic axis, should not be flipped. It should be kept after the surgery. This patient, for example, has steep axis 0, 180 degree, and when we use 2.25 slender at IOL plane, the residual is 0.5, and we are retaining the steep axis against the rule. But if we use the higher power 3 cylinder, we are flipping the axis to 90 degree. Now the astigmatism is with the rule and residual is 0.1. So there are two advantages of keeping the patient with the rule, minimal with the rule. One, that it gives slight depth of vision to the patient, and two, there is a continuous shift with the age towards the against the rule side on the cornea, and this shift is taken care by residual with the rule. So this is how I implant my toric IOLs. I usually implant it under continuous irrigation. The most important step in toric IOL is the size of your axis. It should be around 5 to 5.5 millimeters, so that it overlaps your optics from all directions, 360 degree. That will significantly decrease the chances of rotation. I use my irrigation aspiration cannula itself to rotate the lens to the desired position. And once the lens comes to the desired position, I keep my continuous irrigation on and hydrate the main port and the side port. With this method, you do not get any fluctuation in the anterior chamber. And finally, before closing, just rechecking the axis. You should keep on rechecking your axis and your position of the lens until the end of the surgery, until you remove your speculum. And with this, I think you will get the perfect outcome in all your toric patients. Thank you very much for patient listening.